So hip arthroscopy really has come much more into the limelight in the last 10 years. The technology has been around since the early 80s, but in the late 1990s in Switzerland, a gentleman named Dr. Gans came up with an idea to dislocate the hip out of the socket, and suddenly previously unknown forms of hip pain could be delineated and treated through that type of surgical approach. Well, that requires an inpatient admission, and professional athletes have a difficult time getting back to return to sport after a big surgery like that. So some folks, including some folks in the United States, decided that there should be a way to do this arthroscopically, and the technology increased to the point where now we could do it. So advances in technology and in techniques allowed the same type of procedures to be done through 2 small incisions. So now, with 2 or 3 small incisions that are approximately 1 centimeter in length, we can go in and treat a lot of problems in the hip. These problems typically aren't arthritis. These are problems that occur before people get arthritis. And what happens is some people are born with a little bit of extra bone, either on the ball or on the socket of the ball and socket joint, such that when they come up into certain positions, those 2 bones can pinch because the space between them is decreased. And this is a dynamic process, meaning it doesn't matter how much bone you have. If you're a ballet dancer and you can put your hip into a position that nobody else can really put their hip into, you could impinge and pinch. Or if you're sit at a desk but have an enormous amount of extra bone, you could still pinch, even though you're not doing crazy things with your legs. So when those 2 bones pinch, there's a piece of tissue that runs around the outside of the socket, and it's called the labrum, and it serves 2 major purposes. One, it serves to deepen the socket to provide more stability, and secondly, it lies right on the ball to form a suction seal, to essentially create keep a thin layer of fluid between the 2 bones, keep it well lubricated and low friction. Well, when those 2 bones pinch, that labrum can get torn. And when it's torn, 1, it hurts because it has nerve fibers in it. 2, it doesn't heal very well on its own because it has a poor blood supply. And 3, it can't form that suction seal anymore. So what we can do through the scope, which means putting a camera in one of the incisions and tools in the other, is go in and actually burr off some of the extra bone on the ball or the extra bone on the socket and repair that labrum down to the bone of the socket with some stitches. And by burring off some of that bone, it creates a nice bleeding bed for it to heal, and we can more normally recreate the seal that is present and recreate a more normal anatomy so that they don't pinch anymore. Now, the surgery is done at this point in time to improve pain and improve function, but the goal eventually would be, hopefully, that it decreases the risk of arthritis in the future. We've known since the 1920s that people with these type of deformities on their bones get arthritis at an earlier age. Unfortunately, we haven't been doing this for 25 years, so we don't have a long-term follow-up that shows that our intervention actually decreases the incidence of arthritis. I get a lot of questions about what to expect after a specific surgery, and so we'll start with hip arthroscopy. There's a lot of jazz that goes along with the hip scope after surgery. So there's a hip brace that a patient wears for 3 weeks, and that's to prevent their leg from extending backwards or out to the side. They're allowed full motion in the front, but we try to limit for the first 2 weeks how much time a patient spends at 90 degrees of their trunk to their legs, because the labrum is loaded most at 90 degrees, and so that stresses our repair. So the patients are often sort of suggested that they slouch down in their chair a little bit or prop up something underneath their rear end to help get them more to a 70-degree angle to help take the pressure off that. Plus, it's more comfortable for the patient to sit or ride in a car at that angle. There's also a machine that provides some ice to the area called a polar care that we use for 2 weeks. There are some real fancy boots that are black foam that help keep the patient's legs in kind of in a pigeon-toed position for the first couple of weeks whenever they're in bed, because that helps take the stress off the repair in the front. Crutches are used for 3 weeks, and it's called toe touch weight bearing, which basically means about 20 pounds of the patient's weight is put through that operative leg every time they make a step. And that's all done to help protect the repair, to prevent some complications, and to aid in regaining motion after the surgery. Most patients regain the majority of their improvement in the first 6 months. A professional athlete returns on average to play at about 4 months, but for most of us normal folks, it's about 6 months before you're back doing everything you want to do. There are good studies that show that improvement can take place up to 2 years after the initial surgery, but the bulk of it occurs in the first 6 months or so. Now there's one exercise which is incredibly important, and it's called circumduction. And what it is it's a passive motion exercise, meaning somebody else moves your hip. And you can do it in two fashions, and you're supposed to do it in two fashions, which is with a leg completely straight at we call 0 degrees, or bent up to a 70-degree angle. And at those two positions, your friend, family member, spouse, somebody moves your hip around in small circles for about 5 minutes in a clockwise direction, followed by 5 minutes in a counterclockwise direction. And then after doing it at 0 degrees, does it at 70 degrees. So that's about 20 minutes twice a day for 8 weeks. It's a big commitment. You become good friends with that person again. After implementing that one exercise, the incidence of needing another hip arthroscopy for scar tissue formation dropped from 4% to 1% by the implementation of that one exercise. So it's incredibly important that you recruit a friend or a family member prior to surgery to help you with that type of exercise.